Um, Hi, everybody. My name is Madison Haraway, and I work with the Whitney Marsh Foundation. We raise awareness and support patient and families and try to improve access to high quality care for patients and families that are affected by pancreatic cancer. Today, I'm joined by Dr. Simon, with whom Madison Marsh and I have previously spoken about pancreatic cancer care. Dr. Simon is a board certified family and preventative medicine physician. He's also an epidemiologist and currently serves as the Deputy Chief Medical Officer and State Chronic Disease Director at the Arkansas Department of Health. In this role, he provides clinical oversight and leadership for statewide chronic disease programs. Through the Arkansas Department of Health, they have 94 local health units. So, in our discussion today, we're going to be focusing on several important topics that relate to pancreatic cancer care in both the rural and urban settings of Arkansas. So, to get started, my first question relates to epidemiology, and it's what are the current incidences and mortality rates of pancreatic cancer in Arkansas, and how does that compare between rural and urban areas of the state?
Well, thank you, Madison, for having me in this session. Arkansas, as you know, is a pretty rural state, so it's hard to compare what's rural versus urban. Just to give you a bigger statewide perspective, in 2021, we had close to 560 new pancreatic cancer cases were diagnosed in just 1 year. And in any given year, we have close to 500 deaths from pancreatic cancer, which is unique in sense that the mortality, unless detected early, is very, very high with pancreatic cancer compared to other cancers. And back to your question about rural-urban difference, the HRSA designates almost 73 of 75 counties in Arkansas as rural. So, except for Pulaski and probably the Benton County, the Washington County up in the Northwest is considered as rural. So, being a rural state has its unique challenges with the diagnosis and treatment challenges for pancreatic cancer.
Okay. And we'll kind of delve into what those challenges may be. As far as risk factors and disparities go, based on your experience, what are the major modifiable and non-modifiable risk factors for pancreatic cancer?
Sure. So that's a great question. So the non-modifiable risk factor would include age. As one ages, older adults tend to have increased risk for pancreatic cancer. Those who have family history of pancreatic cancer are at increased risk. Those who have some genetic syndromes associated in the family have increased risk. And having said that, the non-modifiable, which we can all make a difference, includes tobacco use being a leading one, followed by obesity, diabetes, which is a consequence, bulk of type 2 diabetes is from obesity and its metabolic consequences leading to diabetes, and those who have chronic pancreatitis from either genetic or acquired conditions can have increased risk. So, to simplify it, I think tobacco and obesity being the major driver, and diabetes is a major driver. Those are the modifiable risk factors.
Mhm. So lifestyle changes would be important to try
Yeah,
to mitigate your risk.
absolutely.
My next question for you, with more common types of cancer like colon cancer, breast cancer, we have these routine screening methods. What do you think is the barrier to getting early detection of pancreatic cancer?
So that's a great question. So I mentioned to you about the survival rate. The 5-year survival rate for pancreatic cancer is less than 50%. It's about 42%. So, which begs the question, what we could have done early to identify pancreatic cancer. Unfortunately, to date, there's no guidance from the scientific literature for general population,
Mhm.
those who are at average risk. From the US Preventative Services Task Force, which is what we usually follow, there's no screening test for that. Having said that, that's for average risk people for universal screening. There's no guidance for pancreatic cancer. However, studies have shown that individuals with a high risk, such as the genetic predisposition or strong family history, can benefit from annual surveillance, such as talking to the doctor and having that shared decision making in potentially having an ultrasound or an MRI has been recommended for those with strong family history and those with high risk genetic components are recommended to have those. So if someone has that, we recommend that. But for average risk people, there's no screening, universal screening for pancreatic cancer.
Do you think Arkansas specifically has some barriers, like along the lines of like health literacy or primary care screening, or even cultural or language barriers that can kind of hinder getting appropriate screening?
Absolutely. So again, this is a cancer where you have less than 50% survival, right? High mortality. So knowing those signs and symptoms and also knowing the family history, genetic history would go a long way. And that's where Arkansas has a lot of challenges. One, we have a low literacy generally, not just a health literacy, overall literacy, and also we are a rural population, socioeconomic challenges. So those combined makes it challenging for people to be aware of it and the need to talk to their physicians early about if they have signs and symptoms or if they have a family history of pancreatic cancer.
Right. Um, And in your role as the state chronic disease director, and also with your epidemiology background, are there any programs in place in Arkansas that are helping to promote detection statewide, or any programs that are specific to pancreatic cancer?
To my knowledge, nothing specific to pancreatic cancer, but we work with the Arkansas Cancer Coalition, the Arkansas Department of Health. Arkansas Cancer Coalition is a grassroots organization, and they have presence statewide, and they work with the communities across in raising awareness about knowing the signs and symptoms of all cancers, including pancreatic cancer. Some of the unique symptoms, oftentimes the one of the challenge of pancreatic cancer is it's a silent killer for most part. So the symptoms don't happen unless it's very advanced. And oftentimes people may notice some weight loss, abdominal pain that's going back, or having some nausea or vomiting, or some having the color change in their skin if they have jaundice. But oftentimes those are advanced stages. One of the things we've been working with the Cancer Coalition is on educating people about knowing family history of cancer and the genetic history. So to know, it's not just enough to say that, okay, my grandmother had cancer or my aunt had a cancer. We need to know what specific cancer. Is it pancreatic cancer or is it breast cancer or whatnot? Because there are cancers which has genetic link, which would increase one at put them into higher risk, not at average risk. Having that knowledge would help them to talk to their primary care physician to for high risk surveillance through ultrasound or MRI if there is symptoms or if they have or do not have symptoms.
Right. That makes sense. Because I feel like, if you didn't know otherwise, that you would think only a specific history of pancreatic cancer would put you at risk other than these um, cancer genetic links that could be something
Mhm.
other than pancreatic cancer. Um, and with the Whitney Marsh Foundation, a lot of what we try to do is improve awareness. And we have our, monthly e-newsletter that we send out to our readers and try to help. And that's what we're doing with this interview right now is helping to spread that information
Mhm.
about what to look out for and connect families to resources. In your experience, what strategies have been really effective in raising awareness for pancreatic cancer and other types of cancer in Arkansas and helping people get connected to, information and resources that can get them started?
I think public health campaigns, grassroots educational efforts have really worked. We have our annual cancer summit every year. That's usually in the month of March, and where we bring in hundreds of cancer advocates, researchers, experts to promote awareness about cancer and know cancer is not a one disease. It's 100 disease put together. And while some cancers share some common traits like genetic exposure risk, most cancers are separate entities by themselves. They have different risk factors. So it's important to know the family history of cancer more so with what specific cancer they had. And also, it's important to know what are the signs and symptoms because early detection can make a difference between life and death for many cancers where there's more treatments available now.
My next question for you is, um, how well distributed do you think cancer care resources are in the state of Arkansas, like in terms of oncology specialists, imaging facilities, and also surgical centers? Do you feel like obviously that's more concentrated in urban centers? How much of a reach do we have to our more rural areas?
Well, I think we started with the defining Arkansas as a rural state. One of the challenges is the resources. Most of our cancer treatment centers are located here in Little Rock or in Fayetteville, Bentonville, Rogers area, which puts a vast swath of the state without oncology specialists. Having said that, several of these big centers, I know that the CARTI and also the UAMS Winthrop Rockefeller Center have started having satellite clinics across the state to fill the gap so that people don't need to travel 2 hours or more for cancer care because some may require weekly chemotherapy or radiation therapy, and it is definitely a challenge. Arkansas is a picture of challenges, but as it relates to cancer care in rural areas.
Mm. And we've heard of these breast cancer screening vans, and I think they are in the works of doing a van that does low dose CT scans, even for people that have a smoking history and could be at risk for lung cancer. With pancreatic cancer being something that's less common, and again, there's no universal screening method. Um, how do you feel like patients are best screened? Do you feel like it's by, seeing a primary care provider regularly, or what is your opinion on that?
Well, so, as you mentioned, that pancreatic cancer, there's no universal screening for average risk. So, the key things I tell my patients are know your family history of cancer. What type of cancer, and also know your body, the signs and symptoms. Earlier detection makes a huge difference with that. So, in my practice, for people with high risk, I do offer them abdominal ultrasound to start with to look for pancreatic cancer and other associated condition that can cause some of the symptoms and signs. So it is key to know the family history, know the genetic history of the family, and also knowing the signs and symptoms early and talking to the primary care provider during the annual visits so we can find things earlier.
And that makes sense with the pancreatic cancer symptoms being so non-specific. Whereas, breast cancer and some of the more common types, there's, a mass or something
Mhm.
that kind of can clue you in to get screening and appropriate care. Okay, my last question for you is related to collaboration and partnerships moving forward. Are there any collaborations between maybe UAMS, the Arkansas Department of Health, local clinics, or nonprofits that are trying to address these gaps in pancreatic cancer when it comes to rural areas?
So I would say from there is a increasing interest in the research
Mhm.
on pancreatic cancer because pancreatic cancer and melanoma are the two fastest growing cancers. That's important. So one of the things we do at the health department is we monitor trends. We look at epidemiological data. And in the last 10, 20 years, the two cancers which have exploded are increasing is pancreatic cancer and melanoma. So having said that, so we have a slew of researchers looking at why we're seeing an increase in pancreatic cancer. From the partnerships and collaborations, as I mentioned, we work on two set of partnerships. One is the community outreach through the Cancer Coalition, public education, and the other is the academic and also treatment things. So we work with the CARTI, we work with the Winthrop Cancer Institute in looking at the cancer data from the registry. Arkansas Department of Health also has a cancer registry and work with them to see where are the gaps in cares. Look at the data at the county level to see where are the hot spots, where are the high numbers of deaths happening in Arkansas with pancreatic cancer, and to see whether is that hot spot is due to low screening, high mortality, and if so, what is happening? What are the environmental exposures? What are the access issues? So we do have this two-prong approach in reaching the community, educating the public on the family history, signs and symptoms, genetic history, but we also work with the teaching institutions, researchers in identifying those hot spots and identifying the treatment gaps and in filling those through working with those partners.
I'm interested to see where that research goes because it's really demographics and social factors like play such a big role. Um, so I'll be interested to see what we can find from that, especially if there's certain areas that have more of an incidence of pancreatic.
Sure. Yeah.
Okay. Well, thank you so much for your responses and all the work that you do at the Arkansas Department of Health and also as a physician. We really appreciate you taking the time for this
Sure, sure. Yeah.
and to sit down and talk with us. So I will let you get to your afternoon clinic and have a great rest of your day.
Well, thank you and appreciate you talking to us and good luck for your match and
Thank
let
you.
us know we are here anytime. I hope you get to stay in Arkansas